Patients with complex medical and social needs are often challenging to treat in a traditional medical encounter. An intensive high-touch care delivery model in an outpatient setting can improve value for patients, providers, and payers. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly with AHA Communications. In this podcast, Julia Resnick, Director of AHA Strategic Initiatives, is joined by Dr. Stacy Bank, Medical Director of University of Utah's Health Intensive Outpatient Clinic, and Chad Westover, CEO of University of Utah Health Plans. You'll hear Dr. Bank and Chad discuss how the clinic is partnering with the health plan to provide wraparound medical and social care to some of the healthcare system's most at-risk patients, and how the new model of care is benefiting the patients, the clinicians, and the health plan.
Dr. Bank and Chad, thank you so much for being here with me today and doing this podcast. I'd love to start with some background. So can you tell us about University of Utah Health and specifically the Intensive Outpatient Center? How would you describe the community that you serve?
Yeah, maybe I'll start off and Dr. Bank can follow up. So University of Utah Health is comprised of hospitals, clinics, behavioral health institute, and health plans with a group of physicians. And so we are an integrated system of care. And I'm with the health plan side and the intensive outpatient clinic, and we'll get into that, I think, a little bit more, but is an interesting piece to partially solving the issue, some of our most underserved population. And with Medicaid being a large portion of what the health plan does, we partnered with Dr. Bank and many others in a collaboration to see that our members get the services that they need, outreach that they need, and all at the same time helping all parts of the healthcare system.
Right. And so the population we serve has really had difficulty with access to medical care, whether they have been economically marginalized, socially marginalized, have addiction issues. So this is really a population health effort to try to identify patients within our system for whom intensive outreach and a really intentional hands-on effort would have impact on their medical and behavioral health.
Absolutely. So what was the impetus for changing how you provided care for these patients, and how did you know it was an issue for this population?
Well, it started, I think, with the health plan realizing the increasing costs and needs among our population, the Medicaid population primarily. They had needs that just weren't able to be resolved in a 15-minute physician visit in a clinic that may or may not be close to them, and so many other needs and social determinants impeded their access to appropriate care. Because of that, we were seeing the costs go up and up for this crucial population. And so the impetus was twofold: financial one, but also the needs going unmet by the population that was clearly needing some help more than what the traditional system of care has provided. And so I guess that's the impetus behind it. And then a collaborative effort on the part of the University of Utah healthcare system got together and created this intensive outpatient clinic. And given that the most of the membership in the IOC was coming from the health plan, and therefore the benefit, the financial benefit, would be accrued by the health plan, we stepped forward and funded the IOC. And Dr. Bank and her wonderful team have taken it from there and really made a success out of this. Dr. Bank, did I accurately represent the population and what the impetus was for the creation of this?
Yes, absolutely. I don't have much to add. I was listening, and every time you speak about it, I think I learned something new as well. So it's really interesting to think about how this started. But yes, I think that you really captured the spirit of how this all came to be.
Wonderful. So, Dr. Bank, can you walk me through what care looks like in the IOC? And do you have any stories that could bring that to life?
Oh, I can, and I do. Every day is a new story that can bring this to life. So we're an integrated care model. We have on-site medical, on-site behavioral. We have case management. We have an administrative staff, home health nurses that we work with. We have contacts within the psychiatry department that act in a consultative manner, addiction services in a consultative manner, and here in the clinic. So we really want to provide comprehensive integrated care to our patients under one roof. And that really is the basis of what we're doing here. So patients come in and will have a medical appointment with me or my partner, who's a PA, Kay McMahon, and will then see one of their behavioral health team. So we have 3 social workers that work with us, actually 2 social workers and a behavioral health therapist who's also an art therapist. We have 2 medical assistants. We have an administrative operations manager. We have a case manager. I don't think I'm forgetting anybody. We work with home health. So really we incorporate all the aspects into a person's care. We see them often. We see them regularly. They see their behavioral health therapist regularly. So we really work collaboratively to take care of them. We consult each other after our visits. So if I have a medical visit with someone and a behavioral health issue comes up, I'll walk over to the behavioral health therapist and we'll talk about it. And then vice versa. Medical issues come up all the time in people's therapy. So then they'll alert the medical providers, and we're really able to take care of the patient comprehensively in that way. So that's the idea of how we work. We all sit together in one room where we're all, it gets a little much. Like I came over here to find some quiet time because it does get to be a little loud over in that room, but it also is where the magic happens. It's where we can sit and hear each other talking about our patients, and we have easy access to each other to really make sure we have hands-on closely with taking care of our population. And I was thinking about, I knew the question about examples would come up. And so I was just trying to think. And yesterday, the timing's really good because yesterday was kind of the most IOC day I've had in a really long time. Just, we see high intensity patients, but because of that, we have a low volume of patients and we have time. We have time to spend with our patients because of that low volume. And yesterday I brought a patient in. We have a morning huddle where we all get together and talk about what our day is going to be like. I brought a patient in for a sore throat. She ended up having a pretty significant medical crisis in the office, and we have time and we have people there to be able to handle that. Because of that, I was late for my next patient, but all we did was swap my visit with the behavioral health therapist. So behavioral health went first and then I went after, because we're all there and we can all figure out how to do that. I saw one of my diabetic patients who has some peripheral neuropathy in her feet. And we spent a lot of time talking about her feet and her shoes. And she had these very floppy soled shoes that offered no support and no protection. So while she was in with the behavioral health therapist after me, our operations manager ran to the drugstore and got her a new pair of shoes, came back. We put these thick soled shoes on her feet and then sent her out the door. And this was all just yesterday. I saw a patient, Chad, you'll be interested in this one. I saw a new patient who in the last 12 months has cost the health plan about $250,000 and started day one with us yesterday. And he just hasn't had care. He's been going to the emergency room. He's chronically ill. He's been having prolonged hospitalizations. He hasn't had a medical home. And he was really excited to get in with us and realize that he had medical behavioral health, that we're just going to start seeing him weekly, a couple times a week, and hope to really engage him. And I saw him for about an hour, and then I got a call from radiology at the end of the day about a patient who we'd sent for some imaging, who needed some follow-up imaging, was able to call over to CT, get her CT scan, call the gynecologist on call, get a consult, send her home. They had offered an ultrasound. They said, "Do you want us to just send her to the emergency room?" And I said, no. I have time. Let me do what I can. And was able to call the people I needed to call. And a lot of that as a primary care doctor, I know because I've been in traditional primary care for a long, long time. I know that's just because I had time to do that. A lot of this is time driven and productivity driven. And if I take the time to do that, I'm, affecting not only my day, but everybody else's day too. And so I was able to do all of that and leave at 5 o'clock with everybody else. And, we talk about this being a win-win-win for the medical health plan, for the medical providers, and for the patients. And so, like I say, the recording of this and talking about this today seems to be in good timing, because yesterday I was just all day long saying, this is it. This is what we're supposed to be doing. And we're able to really make a difference because we're set up to be able to do that.
If I could just add, I joined one of their huddles recently, and what really was, part of the magic that Dr. Bank talks about is they don't just care for the patient. They know the patients. They know the bus routes that they take. They know where they live. They know their dogs' names. They know their favorite food. They know so much about these people, and that builds the trust that the patients have with the care team. And so it really is, especially when people may have a distrust of any system, or may have some determinants of health or obstacles to health that are not traditional. Dr. Bank and her team are able to understand those needs and have access to the resources that they need. And it's not just I'll see you, the next time you come in, and that's the next time I'll think about you. It's not that at all. It's a team that's comprised of people that know these patients, know these individuals, and treat them like individuals and really like family.
These stories are so powerful, and there's so many different threads that I'd love to pull on and dive into, especially around, how we can design care that really sees people holistically, not just their medical needs, but their social needs around them. And I think a lot of that comes from having these interdisciplinary care teams that have the ability to not just see the medical side, but the social side. So can you talk a little bit about how you fostered a culture of interdisciplinary collaboration? Because I know that doesn't necessarily come naturally and needs that support.
Yeah, definitely. And I think, like I alluded to earlier, we all sit together. I give the social workers a hard time, because we talk a lot. I always tease them. We talk about our feelings a lot, and so we've learned to really be effective communicators, not just with our patients, but with each other. And I really can't emphasize enough how much we collaborate as a team. We have our morning huddle, like Chad was talking about. We have a 2-hour meeting once a week where we divide our patients up into different groups and talk about them very extensively with our psychiatrist, with the addiction team, with the case manager, and we just go down the bullet points, make sure we're not missing anything, give a kind of a status update on everybody. We have an operations meeting once a week where we all have an equal voice. We very much make decisions collaboratively, not just about our patients, but about the operations of the clinic. And so we really like each other. We do group activities together. We make sure we're taking care of our own mental health. We talk about our own mental health. We are always checking in with each other. These are difficult patients who have experienced a lot of trauma, and we want to make sure that we're our best and healthiest selves to be able to take care of them. And so we have fostered a really collaborative work environment in which we like each other personally and take care of each other personally. And that really spills over into our professional relationship that we're able to extend that to our patients.
That is wonderful. And I want to pivot to a different sort of teamwork, and that's the teamwork between the IOC and the health plan. So can you talk about how that partnership worked and how it developed?
Yeah, I can lead with that. And some of it is data, right? We have to understand where our membership is in their needs and their financial situation. And we need to understand what we can do to help them. So we look at our records that indicate who is in most need of the IOC. and who can benefit the most. Now, we've identified more than what we have right now, and we're looking towards expanding the current population. But up front, we would look at the data to find our members and talk to our medical management team, our care management team that works with these members. And the traditional approach is that those care managers work very closely with members and help guide them to efficient sources of care and help them personally. But there are some individuals that, they could work, our care managers could work 24/7 with certain members and not still be able to provide all the care that they need. And that's when we look at the IOC as a good alternative for some people. Obviously, it's not for everyone, but when they do get into the IOC, that's where, as Dr. Banks says, it's a win-win-win, because the member finds a place of trust, of access to care, and it doesn't just stop with medical care, right? As Dr. Bank talks about it, it's all forms of needs of the member. And so we are, happy to be able to provide this service to our members that need it. And as Dr. Bank and I talk, where is the next level of care that's needed, and we're having to look and see who those lucky individuals are that can go into the IOC and have that type of service provided for them. And so the relationship is one, as I said, we financially fund the IOC. We provide membership to the IOC and working with them collaboratively to see who would benefit most from those services.
And I would also add just to that we do talk about partnering with UUHP, with the health plan, and I don't necessarily consider it partnering in the traditional sense that you have two established entities that enter into this kind of mutually beneficial relationship. This was really an idea that was supported by UUHP from its infancy and grew it, So, this was something that health plans made an investment, both financially and just took a risk with the developers of this clinic. And so, yes, we're partners now, but really as it started, it wasn't like we had two specific groups that decided to partner together. This was something that was grown and really kind of got us to the place where we are now.
I love to hear that. And so, kind of staying on this line of questioning, I know that when hospitals or healthcare systems are thinking about adopting some of these different care models, like intensive outpatient care, interdisciplinary teams, they need to make the value case for why this makes sense for their patients, for the organization. In your experience, how have you made that case? How would you advise that others make that case?
I think Dr. Bank makes a good case that it at first is a bit of a leap of faith that this is a model. You could look at it intuitively, knowing that some of your members need greater access to care. And so that's not hard. Funding it with a interdisciplinary care team that we have is a bit of a leap to fund that initially. But it certainly has been the right thing to do for the members. It certainly has been the right thing to do financially. We've tracked the value of this. And so for the last 3 years, we've seen over 230 patients cut emergency room admissions by 80%, cut hospitalizations by 30%. And this is because they have a place to go that is a better source of care. It's not about denying care. It's not about limiting access to care. It's about providing the care that's needed. And that's where the magic is that it works financially, but more importantly, it works for the members because they are getting the care that they need at the place that they need it and at the time that they need it. So it really has been a success on every measure.
Speaking of successes on every measure, we're always interested in impact and really being able to articulate the impact that these had. So, Chad, I know you described a little bit the outcomes you've seen. Are there any other ways you've been measuring the impact of this, especially related to outcomes, the patient experience, or cost?
Yes, and we have been tracking patient-reported outcomes, and that's been pretty interesting when you look at the areas of depression, physical function, and overall general health. All of those have significantly improved patient-reported outcomes, especially when you start to extract severely depressed, poor physical function, poor general health. When you take that out and look at those, you see tremendous gains that the patients are self-reporting in those areas. And so that's been really very inspiring to see. And then when we compare ourselves cost from before they start us with us, I should say, the average cost, and Chad, you can correct me if I'm wrong, the numbers I have are about $55,000 per member per year. And we cut that more than half down to about 25,000 at the 1 and 2 year mark. And that's average per member. So some of those are a little bit more, some of those are a little bit less, depending on our starting point. But we have a statistician that we work with through University of Utah Bioinformatics, and we've been able to track this pretty closely.
Anything you wanted to add there, Chad?
No, I think that Dr. Benk is pointing out it's certainly a very important part of the mental state of our members. And when access is not available and you don't think that you have a team or a person or someone that not only cares but can provide the resources for you, and you're struggling with health, physical and mental health, it does get very dark, and it gets difficult to know where to go and where to turn. And that's one of the things that the IOC team provides these individuals, is a place that they can trust, that they know that has their best interest at heart. And as I have listened to them, I mean, as they share stories and they talk about their patients, as they talk about their own personal needs, I mean, they're clicking on so many fronts that, there's times where they shed tears together over what's going on with patients and what needs to happen. And again, it's not just a job that, they see a patient for 15 minutes and then they, again, don't think about that patient for, weeks or months. It is a place of care and of concern for these members. So it really works well.
So I'm going to ask you both to take a step back and think about what lessons you've learned over the course of doing this work that you could share with our listeners.
Oh gosh, where to start? I think lessons learned, I learn new lessons every day. I have lessons in and compassion every day. From a simplistic medical standpoint, I feel like this is the kind of care we all want and all deserve, and we're able to give it to a population that might need it most. I think I've learned how to practice in a way that regenerates me instead of depletes me, which is happening for a long time. And I've really learned that the patient will tell you what they need. The patient will tell you how to help them if you can stop and really listen to them and really hear what they're saying. And so I've learned to just slow down, sit with them, listen to them, hear them, and you'll get where you need to go.
From a health plan side, it's easy to slip into the mode where you're just looking at numbers. You're looking at what financially makes sense. You're looking at, how all of that works out financially. And one thing that this partnership has really forced us to look at is to look at the individual more as an individual, and not as a pool of individuals that need this kind of care, but as individuals in need of access to care and in need of people who are there for them on a ongoing, regular basis. And so it does become about care about the one, care about the individual. And that's something I think that we all need to reflect on. But for the health plan side of things, it's not as frequent that we look at things in that way. And so I have really appreciated the opportunity to work with Dr. Bank and her team and to see things from less of a dollars and cents, less as an aggregate, and more so as how we can help the one.
Absolutely. So what's next for you both in the IOC? What are your future plans?
Gosh, I have big dreams. I know I have big plans. What's next for us? We're looking for a bigger space. We certainly want to be able to access more patients that need our services. We are in the middle of partnering with the dental school, the School of Dentistry at the university, to be able to access dental care to our patients. We have met with the Utah Department of Corrections to start to think about how to help some justice involved of the population, and really just figure out a way to give the most comprehensive we can to more patients. So grow, right, Chad?
Yes, and that does make a lot of sense for us. I mean, there's certainly more people within our membership that could use the IOC, and we're certainly willing to grow the numbers that fall under the IOC and have them care for those members. It's not always easy in every circumstance to grow as much as we would like, but when you do look at the success that we've had so far, and the interesting point that I've made is, where is the tipping point, right? How sick, the low-hanging fruit almost are those that are really in need of a lot of services. That's the easier ones to say we can help them in an IOC model and reap a lot of benefit. Where is the tipping point that we get to say the IOC is good for this level of care and needs? And I think that's what our next step is to find that point where we can service as many people as we can and as many needs as there are to reach that tipping point.
A really powerful example of how we work and what we do is demonstrated in a short film that was just made about our clinic, produced by University of Utah Health, called Meet Me Where I Am. It's accessible on YouTube through the University of Utah Health channel, and it really demonstrates a significant patient example and shows our team in action about how we're able to care for this population.
That's an incredibly powerful video. And for our listeners, if you look at the podcast description, we'll include a link there. Well, I look forward to seeing how your work continues to grow, because really this is how we should be providing care and seeing people as our patients as whole people, being able to address all of their needs. So I just want to thank you both for taking the time to share your work and your story with me. I think this is going to be a really powerful example for our hospital listeners, and hope that they're inspired to think about how they can implement this in their own communities. So Dr. Bank, Chad, thank you both so much. And thank you to our listeners for joining us today.